Hi, everyone. It is 1:35, I'm sorry, Mountain Standard Time. It is 3:35 for you guys back east. Don't ask me what you are in Hawaii. Have no idea. This is a general session for Wednesday, October the 6th, where it's about saving young lives through collaboration and technology. And we welcome everyone to this session. As a reminder, all sessions are being recorded for posting on the NAME website and for future viewing by the NAME members. We would like to remind everybody that today's audience may include representatives from federal agencies, including CMS, US DOE, and the OIG, as they are all participating in this virtual conference. All participants have been muted, and we ask that you submit your questions via the chat box. We'll have time at the end of the presentation to address questions, but our panel has also said that if you have questions about something specific that they're talking about, we can all interrupt them and have them answer you guys' questions. And I'm pleased to introduce our speakers for this presentation. We have Kevin Bauer from the Medicaid School Services Policy Specialist, Michigan Department of Human I can't even see what it says. Sorry, Health and Human Services, I'm sorry. Scott Hutchins, School Mental Health and Medicaid Consultant, Michigan Department of Education, and Nick Jaskew, the School Psychologist, Michigan Association of School Psychologists. Welcome, guys, and I'll leave it on to you guys.
Okay, thank you very much. And I just want to say, as far as having a virtual conference this year in Hawaii, I am going to miss the chance to bid on your amazing macadamia cookies that we always bid on each year. So one of the disadvantages of having to be virtual. Looking forward to the day when we can get back to in person. So for all of you that joined us yesterday for the general session, what you've seen was the beginning of our program, and today we're going to take you into a little bit more in depth of how we managed to work through one of the hurdles that we experienced in our state. Just a session overview here, and that in recent years, the governor and state legislature in Michigan has allocated funds to improve behavioral health in the schools through the State School Aid Act. Actually, it was $31 million in the first year, as you heard yesterday. Prior to COVID, we knew that there was certain mental health needs in the school, and that those needs were significant. After that, after the pandemic, we anticipate those needs climbing disproportionately higher. So meaning that it's all more important that we meet the needs of those kids with their behavioral health concerns. Also, the disruptions in traditional in-person learning has caused a lot of problems, as you are all aware. Other things, you know, with the lack of social contact and things like that, it has just led to a huge problem in our schools. And we really, through our efforts, are attempting to meet those. As we talked earlier about the School Aid Act and 31N, it kicked in funding that was much needed for those programs. However, how we were going to administer those programs and the roadblocks along the way, that was something that we were still looking at. So in addition to what you heard yesterday about the journey in Michigan to increase Medicaid services and services in general to the schools, this will be an even more in-depth explanation of how things are going there. Next slide, please. Scott, is this one you were going to cover?
Sure, I'd be happy to. So just an idea in terms of the national context and how we got here. As a result of, a lot of critical incidents that were happening across America, there was a big push for responding to those crises and those critical incidents. And many states focused more on, we'll call it hardening their schools and looking at things such as, gated entries that are not gated, excuse me, but locked entries. So you could only come into the office if you identified yourself on camera or provided some type of ID. There was a lot of push for things such as bulletproof glass. And again, all of those physical type hardening of the structures of schools was initially one of the big pushes as a response. Michigan, however, took that a step further and really looked more at not just the hardening of the schools, but what is actually causing our young people to hurt other young people and themselves. And we came back to critical conversations around behavioral health and mental health issues were why that was taking place. And so Michigan, through the State School Aid Act, allocated a great deal of funding, as Kevin mentioned, to add behavioral health providers directly in schools to provide services to students. One thing we like to point out, that second bullet about school safety, it's an issue that needs to be tackled from multiple angles. I had the privilege yesterday of presenting to several students across Michigan, and they're just as critical to this as the staff are. And when we talk about staff, we mean all staff, from bus drivers to cafeteria employees, teachers, teacher assistants, playground aides. Everybody needs to be part of the system and part of the solution, including our students, looking out for each other and being self-aware of what their own needs are and really sharing their own experiences so we can get them help if they need it. Obviously, access to mental health services is a critical component for both crisis prevention and crisis management. And we're very fortunate that the Centers for Medicare and Medicaid Services support those efforts with the Medicaid reimbursement, which in Michigan is known as Caring for Students, or C4S, to get better access to behavioral health services. I'll pass it back to you, Kevin.
Okay, and the way we did that is we started to expand based on free care to increase our services from students just with an IEP to students across the board. And what that did was we were able to increase our services from, it should be 108,000 to 980,000. So a big increase in services, and in particular, mental health services. When I first put the ball in motion to try to increase this program, I really didn't know what we were going after, to be quite honest. I knew I wanted to increase services across the board. I really hadn't thought about how much of that would be the OT, the PT, the speech, and things like that. But so we increased services across the board. Can we go to the next slide, please? So as we've seen, not all programs or all types of services increased uniformly across the board. We've seen almost no increase in OT and PT, which you can imagine would be slow to increase because that is more for your students that are with an IEP or an IFSP. We did see a modest increase in speech and personal care service, and we've seen a little bit more of an increase when it came to nursing services. However, that was not our main goal at this point. This is the point where we realized that this was an opportunity for the state of Michigan to really hit heavy on those behavioral health needs of our students. Like Scott said, you know, there's an aspect of putting the bars on the windows, the metal detectors and things like that, but that doesn't address the base problem. And that is the mental health of the students themselves, whether it be self-harm or harm to others. Now, one of the significant requirements of the program is the coordination of services across with other provider types. For example, you have the behavioral health technician within the school, and they're trying to connect with the primary care provider. They may be trying to connect to a community mental health provider or any other provider as appropriate. And we found that it was just pretty tough for them to meet all these different connections. You know, it was a lot of time being spent trying to connect silos. If you hear, well, you'll hear that term, that we had silos set up. We had community health in one place, we had the schools in another, we had the personal care primary care providers in another. And it really was not a lot of communication going on between those. And this was especially difficult when you consider that we increased the number of school providers in the mental health area by 64.7% within a few months of the program starting. So this was an influx of new providers, new clinicians that had not previously been involved in school services. So that was the big challenge that we had. So another thing is we wanted to ensure consistency within the program. We wanted to make sure that evaluations were being conducted relatively the same across the state with similar results and things like that. We also wanted to be able to access behavioral health records in a way that providers could access them and securely access them. We also wanted to be able to track referrals and make referrals from, for example, from the school back to the primary care provider or to the community mental health agency. And we also wanted to ensure a standardization of billing to some extent so that not everybody was trying to do their own thing and we could flow them smoothly into our automated billing system. Next slide. So the solution to that was that we needed to develop or obtain a system that would easily allow evaluations in that system and also referrals and a connection of all these different silos that were responsible for the mental health of the students. So what we found is, as you heard me talk about yesterday, we had $1.3 million for infrastructure changes to develop a new program for billing and also to hire individuals. Well, that was great. And we also found that once we had that program in place, the funding actually shifted to another area so that it freed up those funds to be used in another way. So that allowed us to bring a system on board that would help us with the very things that we needed help with. Next slide. I believe that's back to you, Scott.
Yes, thanks, Kevin. So as Kevin mentioned, we were fortunate to be able to reallocate those funds from the State School Aid Act to help us connect students to behavioral health services in schools. As I mentioned before, with that funding, and as Kevin mentioned, a 65% increase in the first year alone, we've been able to add over 300 providers to the state of Michigan through the funding directly in the schools. And many of them are doing some tier 1 and tier 2 services, but we also have several models where they're also delivering tier 3 services and actually providing therapy right within the schools in a safe environment. And what we noticed across the state of Michigan was multiple schools were doing things multiple ways, and that, which is perfectly fine. But we also knew that that was creating some challenges because they had several questions about whether or not they were doing things right and whether they were following the intent of the legislation. And so we spent a lot of time looking for a platform that would create standard operating procedures, provide best practices that we could roll out. And we're going to cover that here in just a minute. That platform is known as bhworks. And the vendor is MD Logics that provides that to us here in the state. But before I jump into that, I want to talk about this diagram a little bit, because this is really the critical component of identifying and connecting students to those behavioral health services. So at the bottom of the pyramid, it starts with that referral or screener. And so when you have a mature student, possibly a middle school or a high school student that asks for help and says, hey, I'm struggling with my mental health, or I'm having these symptoms of anxiety or whatever. Those are students that we can get connected to resources fairly easy. If you've got a student, as I said, that's mature enough to ask for help, most likely you're going to be able to get to find out the student's needs and get them connected. Same thing if you have a trusted adult within the school building who makes a referral for a student, a teacher, a principal, a bus driver notices that, Billy is more withdrawn lately, or he's been missing a lot of school recently. Some of those outward behaviors that we can obviously see could have impact on their behavioral or mental health. So you may get a trusted adult, you may get a parent or a caregiver that says, hey, I need help for my child, they're struggling or whatever. So between trusted adults, parents and caregivers, or self-referrals by the student, we weren't having issues identifying those students because they were obvious. They were either self-referred or they were referred by an adult. But we were very concerned about our silent students in crisis and figuring out how do we identify those students that aren't outwardly displaying certain behaviors that we've concerned about or that another adult hasn't seen. And so we really wanted to find something that would allow us to do universal screening for our schools that had the capacity to implement that. And so that's that other piece of that bottom of the pyramid. So starts again with either referral or doing some type of screening to identify the students that are in crisis so that we can move to the next piece and actually do the assessments. So the behavioral health providers, again, because they're directly in the schools, they aren't waiting 6 months, 9 months, 12 months or more to be connected to a behavioral health provider in the community mental health system. Many schools have those providers directly in the school that can sit down and do that assessment with the child. And through that assessment, again, make a determination on what the needs are for that child and whether or not services can be delivered in schools, or if it's something that's beyond that behavioral health provider's capacity, more intensive services are needed. Again, being connected to community mental health agencies, hospitals, et cetera. As Kevin talked about, that care coordination that's so critical, that takes place once the child's assessment is done, which takes us to the next piece, which is the service delivery. So again, whether that service takes place within the class, in the school, the students pulled out of class, possibly one-on-one therapy or group therapy, but the delivery of services starts to take place. And you'll see how bhworks helps us with the service delivery here in just a second on the next slide. But going to the next piece or the top of that pyramid is that ongoing monitoring and continuous improvement. And this is more than just looking at the ongoing progress of the student, but looking at your system as a whole. So by having access to real-time data through those screeners, you're able to identify why are students being seen by behavioral health providers, or why are we referring them out? Is it high signs of depression and anxiety? Is it substance use? Is it chemical dependence or something like that? So by getting that real-time data through the bhworks system, again, communities, school districts, intermediate school districts, counties can look at their data as a whole and make determination to see, are we putting resources in the right places? Do we need, because, a lot of times schools look at some superficial data like attendance numbers or suspension numbers and say, oh, we have this huge problem. So several students were suspended. But again, if you don't look at what the root cause of those suspensions are, or if you have several chronically absent students, if you're not looking at what the root causes are, you're not necessarily able to fix them or come up with systems-wide interventions. And so that's where that continuous improvement comes in. So when we look at the bhworks elements, and again, as I said, we chose bhworks after a pretty extensive process research around the different platforms that were out there. And this is only some of the features of bhworks. This is the kind of the highlights of what we selected in Michigan. As I mentioned before, it is available for all intermediate school districts in Michigan. We have 56 intermediate school districts, and most of them are typically counties, but we do have some counties that are smaller that merge together their resources. But for the most part, as I said, we have 56 intermediate school districts, which make up all counties across Michigan. We are a local control state, so each school district, intermediate school district, gets to determine whether or not they want to use bhworks. We pay for the platform through the Michigan Department of Education, through those funds that Kevin had mentioned. And we have 31 actually ISDs of the 56. We just rolled this out in March, and we already have 31 that are planning to go live by next fall. And I'll cover that in just a second. So, but again, going back to the program elements of bhworks, starting with the far left, that top orange box, the MTSS enhancement. So again, by using universal screening, by identifying students that are in crisis, you're able to get them into your MTSS system and make determination, do we have a large group of students perhaps that we could put into a group setting to talk about anxiety or depression, or do we need to take them maybe to tier 3, which is that one-on-one intervention. The next, going to the right there, with the gray box, entering and receiving referrals. So as I mentioned before, if you have a trusted adult that identifies a student in crisis, they can enter a referral right in the bhworks platform, and the service provider can receive that referral and make a determination of next steps. Again, we'll go straight across here. This top box, next one is screening, they're in purple. As I mentioned before, the universal screening component gives real-time data back to the provider after the child takes the screener, or if it's a younger child and their parent or caregiver takes it on their behalf. The results are automatically summarized, or excuse me, immediately summarized, and sent to the provider so that they can make a determination on what the needs are for the child. Assessments, again, you take the information that you have from the screener, you do the background on the child. That's where the assessment piece comes in. And then providing services virtually. So within bhworks, there is a telehealth component that's HIPAA and FERPA compliant, which is real critical because a lot of our students that need those one-on-one services and interventions have attendance issues sometimes. Perhaps they're being suspended or sent home for behaviors. Those needs of the child don't go away just because they're not physically in school. So we wanted something that allowed us to connect with those students even when they weren't physically in school. And we can do that through the telehealth component of bhworks. Going back to the left, the bottom row this time, at the orange there again, maintaining records. Again, all of that information can be stored right within bhworks. We can also exchange secure information. So if you have providers that are connected outside of the school to the bhworks system, such as a primary care provider, you can exchange secure information, and we're going to cover that in just a little bit as well. The next piece, care coordination, that's again where really bhworks has made a big difference in the state of Michigan, because everything from developing the plan of care, obtaining consent forms from parents and caregivers can be done electronically. An email can be sent to them, and that parent or caregiver can sign electronically. Huge game changer for our providers. Instead of having to, hope that it gets home in the backpack and the child remembers to take it out of the backpack and it doesn't get peanut butter and jelly all over it from that child's lunch that they forgot to eat and all that fun stuff that comes with that. You don't have to worry about that because of electronic consent forms. And then obviously monitoring their progress of their goals. And there's also a billing integration piece too. So obviously a big component of our system here in Michigan is our Medicaid reimbursement. And so with bhworks, there's an integration with many of our billing vendors. The last two, obtaining real-time data. Again, you're getting that information back immediately and being able to make a decision based on the student's needs, but also having real-time de-identified data, so you can look at systems as a whole, as I mentioned before. And then recording student interactions for reporting. This is another critical component. We want to be able to tell the legislators the story of how successful the funding has been and what impact it's had in Michigan. They've invested a lot of money in the behavioral health programs, and we're very fortunate of that. But they need to know what the impact is. And so being able to have the data available to us so that we can turn around and show the legislators that we've had over 300 providers hired in Michigan. We've had over 250,000 students get some type of intervention, possibly one-on-one therapy or group therapy or whatever. So all of that information is available in the bhworks. As I mentioned before, 31 out of the 56 ISDs are expected to go live with bhworks by the end of the fall. We're really excited about this visual. I mean, you can see we've got everything from the southeast corner of the state in Michigan all the way up to nearly the northwest corner of our Upper Peninsula. So 31 of the 56 ISDs. And again, we just rolled this out in March, April. And so we've already had that big of a commitment. And we do expect more ISDs to get on board once they start seeing the success of it and building their capacity to be able to implement the system. So the next piece I want to talk about, actually, Liza, is there any questions in the chat before I go on? Okay, thank you. So what is a comprehensive and sustainable way that schools can improve student behavioral health? We have spent a lot of time addressing these questions. Nick, who's going to talk next, has been a great thought partner, well, more than just a thought partner, a great partner, collaborative partner from the Michigan Association of School Psychologists. He is part of a coalition that also involves the Michigan Association of School Nurses, the Michigan School Counselors Association, and the Michigan Association of School Social Workers. And together, we have had a lot of conversations around behavioral health and how we can impact schools in Michigan in a comprehensive and sustainable way. And this is kind of our 6 main points, if you will, that really can be implemented rather efficiently and in a pretty cost-effective manner because of the fact that there is so much attention and focus right now nationally on behavioral health and mental health. So there's a lot of resources available at little or no cost, virtually or online. But it's these are in no particular order, even though they're numbered 1 through 6. But starting with number 1, the gatekeeper training for all school staff on mental health and threat assessment. We feel that's extremely critical. It's not just about teachers in the classroom. It's about the school bus drivers. It's about the cafeteria employees, the administrators, all being able to recognize a student that could be in crisis. Next is that universal screening of all students. We talked about that, how we're able to use bhworks to allow us to universal screen students. Again, we're not doing that collectively as a state at this point in Michigan, but we do have the tools for schools that have the capacity to do the universal screening because of bhworks. So it is available to them. But it's not fair to mislead you into thinking that Michigan is doing universal screening at this point as a state, because we're not as a whole. The next piece is SEL, or social emotional learning embedded curriculum. We feel that's a critical component from kindergarten, if not even preschool, all the way up to 12th grade. Our seniors in high school need to be aware of their own feelings, their own thoughts, and also their peers, being self-aware, but also being aware of how to identify a peer that may be struggling with something. And that can be accomplished by embedding that SEL instruction right in the classroom, right along with reading and math and social studies and everything else that we teach. Number 4, countywide resource mapping and curation. This is taking a deep internal look at your communities and what resources are available. So do you have a CMH, a community mental health agency in your county? Do you have a 31 unfunded provider that can assist another neighboring district? So doing that resource mapping to figure out what are our resources, because the last thing you want to do is screen students and not have the capacity to get them connected to the services they need. That's so critical. And so by doing your countywide resource mapping and in the curation piece, keeping it up to date, monitoring it, so that if you do have students that are finding you're vulnerable and transparent about their concerns about their own health issues, you can get them connected immediately or as efficiently as possible, hopefully. Number 5 is the care coordination platform. I mentioned before, we use bhworks in the state of Michigan. We're very happy with the high level of customer service and just amazing expertise that we get from the company MD Logics that provides their platform bhworks to us. And then number 6, the access to mental health providers. As I mentioned before, you need to be able to have the capacity. If you identify students that are in crisis, it's critical that they have access to the providers that are going to help them get better, especially if, as I said, they're going to be vulnerable and transparent and honest about how they're feeling. The last thing you want is to, get a child that comes forward and says, I need help, and not be able to provide that help.
Scott, we have a question. Do the school districts employ all the service providers, or are they contracted?
Great question. It's actually a combination of both. So with the State School Aid Act funding, it does allow the ISD or the local district to hire the behavioral health professionals themselves, put them on their own payroll, or they can, several of them do contract with either a CMH or even private practice providers. So it's across the board in Michigan on how that works. All right, Nick, happy to turn things over to you, my friend.
Well, thank you very much. And Scott, thank you so much for those really kind words. This slide is very busy, so I'm going to beg for your forgiveness. So when you evaluate us, I'm the guy with the slide, okay? And so we thought we would start with the slide because we're kind of going to do a journey. It's our story here in Michigan, and the slide is presenting the whole, and then we're going to go into the parts of what we're doing, and then back to the whole, and then Scott and Kevin will take care of that last part. But I do want to make a couple statements before we get started. First of all, I'm so happy to be presenting here, and it's a pleasure and an honor. I get to present with two of my heroes here in the state of Michigan, and that's Kevin and that's Scott, because I'm saying that, and I'm being very honest here, is I've been in the field for 33 years as a school psychologist and administrator, and we have never witnessed the collaboration and the work that's going on between the various departments and our associations and our local districts. So my hats off are to these two gentlemen and their leadership. Again, the other part why I'm really happy to be here is that anytime that I get a chance to participate in a presentation that talks about saving kids' lives, I'm in. So thank you, thank you, and thank you. Going to the slide, we're going to break the slide down and we'll get into the particulars. But as you can see, if you draw your attention to the left, upper left right there, and again, Scott did a wonderful job in terms of breaking down the elements of the platform. Realize in our thinking, the platform is critical because it's the highway of exchanging information. And three particular areas that we draw on is the suicide prevention piece, which is critical to us. The second piece is student mental health. And then the third piece, which we have to integrate across the board, is school safety, as Kevin discussed earlier and Scott. So again, that's kind of our logic model that we're following. And that platform is very critical. When you're looking for a platform in your state, you want to get the very best that you can find. And second, you want those folks working with you that are true scientists and consultants. And we have been fortunate in that area. But again, keep that in mind. The other thing that I want to mention is that all of our states, as we get involved in nationally and our associations are all talking and working together, we're finding that we're in the same boat. We have the same problems. We had all these issues pre-COVID, and now COVID is just taking things to a totally different level, which is scary to a lot of us. So again, we're going to continue to talk about that platform. That's a critical element. The drawing in the middle is unique, and we'll talk about that. It's our three summits that we held focusing on suicide prevention. And as you're aware of, when you look at legislation that focuses on suicide prevention and intervention and postvention, here in Michigan, we've got a lot of work to do. And we've been very fortunate that we've got some wonderful partners across the state. They have come together. We started this work pre-COVID, and then we continue it, but it also served as a catalyst to bring us all together in what we're presenting today. And again, there are a lot of spin-offs of this that we feel are going to be very supported in terms of saving lives and helping our students as well as our families here in the state of Michigan. The associations in this area became very important in terms of, Scott mentioned some of them, the school psych, social workers, nursing, our health educators, pediatric folks, and coming together to address this because, again, we want to dramatically enhance legislation that supports a comprehensive process towards suicide prevention and then intervention. and our partners at the department. Was critical that we all work together. And again, Scott and his team, Kevin, they've been facilitating this process all along. But we'll get more into that particular area because, again, that really started our journey together, and again supported the work in terms of bringing on the platforms. If you look at the right side, that's a critical drawing that's going to become more important and evident in our world, and we'd like to show that to you today. That's our Behavioral Health Learning Collaborative of Michigan. It's actually a byproduct of what occurred in the summits. And again, through our story, you'll see how it came to be. And when you think of this, as we're discussing it, I want you to do two things. I want you to imagine your state utilizing this, but then also think about it as not a website, but being a virtual workspace for all of our mental health providers working with youth and family that can connect, come together, and train together. The subheading, Connecting the Dots, Building a Stronger Youth Mental Health Ecosystem, is really what we're after. And Kevin really brought up the issue of silos. And we're taking silo breaking to a new level here in Michigan. Because again, when we talk about silos, many times what occurs is that an agency or group or some multiple agencies get together and they build this process program or what have you, and then they invite people to it. Here in Michigan, we've taken the position that we're actually going to build this together. And again, that's through MDE and MDHHS leadership that this is occurring. But if you look at the bottom, that's just a few partners that we have involved. If we can go to the next slide, please. Okay, so let's talk about our 3 summits, because in Michigan, through some leadership of Representative Merriman and Senator Hertel, and then the support of MDE and MDHHS, we started on this journey really evaluating what we're doing for the prevention of suicide in the state. And again, we feel that we're lacking. And again, when you look at other states, they have their legislation is a bit robust compared to ours, but then there's a lot of states that still are trying to figure that out. And there's a lot of movement in various legislators. So we reviewed all the states, and then we started developing this summit concept. There are 3 summits that were designed and put together. They took place during the month of December, March, and then also June. And the summits were divided into 2 sections. The AM section brought in some experts throughout the field that we felt were extremely helpful in regards to the particular areas that these circles, and I'll explain that to you, how we came about those circles. But we averaged about 285 participants, about 136 organizations were involved. Those were from private providers to school folks to agencies like pediatrics. We have a group, MC3, out of the University of Michigan. Their emphasis is drawing psychiatry to the rural areas. We had members from MDHHS, our foundation that linked all the community mental health. So as you can see, this was a massive undertaking with the various agencies and groups involved. And so the morning sessions brought in people like Dr. Tian, Paul and Brian Quinnett from QPR Institute, just to name a few. So the Sigma Threat Assessment Group, Melissa Reeves. We had our SRO coordinator from the Michigan State Police. So we had a whole host of individuals that came in, and they presented in the morning on particular areas surrounding these circles, because we felt as a team, as we did the research and came together, these were particular areas that need to be addressed when we're pursuing a very legitimate, comprehensive process or within a legislative attempt to move it forward. So we felt that these were important. As you can see, we had a group that specifically worked on curriculum, and all of these breakout sessions occurred in the afternoon. So in the morning, the presenters presented, and then in the afternoon, those sessions were with our teams. There was either a co-facilitator, Actually, we went to co-facilitators. We started out with some individual, and we felt that was important to do the co-facilitation. The crisis line, as you can see, there's a lot of efforts there nationwide. We have a particular crisis line called OK to Say that runs through the originally through the Attorney General's office. Now it's with our state police hub. And so that group was working on that particular element. Universal screening, which we feel is critical to us. And again, we talked a little bit about the platform, and we'll get more into it, but universal screening is critical when you're looking at prevention, tier 1. And most of you are familiar, as Scott was talking about the pyramid, we absolutely are tying everything into the MTS structure within schools because that's the way we tend to operate with all referrals. The other area, as I just mentioned, MTSS as well as PBIS, because again, these two are critical to us because remember, we're not separating the suicide prevention from mental health from school safety. Those three elements we feel that we need to run together. That's critical. Threat assessment is another area that's very important. And as you look at the research and you've heard that a wrong, poorly done threat assessment tends to add to the problem. So again, that was a particular area that we felt was very critical. The other area is the information hub. And we needed to have a place where we got the most validated information available to us, continual research, continual connections with the field, continual connections with researchers to field. And so that was really the creation of the BHLC spun out of that. And we'll talk more about that. The other area that is critical to us is access to school-based mental health. As you know, again, we share a lot of issues across states and the shortage of providers is critical. And remember that it's awful difficult to build that pipeline from the universities. You know, a lot of us like to hang our hat on that, but unfortunately it's going to take years to do that. So what we do in the field is critical. I, as a school psychologist, utilizing a platform like we're talking about really allows me to be more cognizant of my time. It supports me from all the particular areas. Everything's on one site. So it's a time-saving issue. And then it allows me to see more students, which is critical. The other area is in terms of information documentation. We lose students in transition. We literally have students die when it comes to transition. For example, mental health facilities coming back to schools, if that information is in exchange, there are often situations that occur that the school doesn't even realize the student has been in care. The other issue is transition of information, critical information in mental health from school to school. Again, the hospital school transition had its own group, and then diversity, equity, inclusion, basically transcends all the work that we do here. And then the crisis response team is very critical in terms of prevention as well as being activated when something occurs. Next slide, please. Okay, so let's talk about the BHLC, which is a product of the work. In conjunction with this, we are now moving all of our information into the House and Senate champions. And we're also providing ongoing consultation to that team, that legislative team of aides and reps and senators, and they're going to be getting the process of drafting. But with the BHLC, we're kind of using that practitioner's model. Remember that as they're moving the legislation through, we also have activated, you know, the screening mechanism. The bhworks is in place and being deployed, and we're working on, as we speak, the BHLC because again, we're losing kids on an ongoing basis. So we're trying to get the good practices out there. The BHLC of Michigan, basically, think of it as a virtual workspace. It's an online community of practice to share best practices and resources, host professional trainings, and we're talking cross-training. That's critical to remember. I'll speak a little bit more to that. And then awareness efforts, around the mental health issues and resources that are available. Remember, part of the work that we're doing is we're literally attacking the stigma in Michigan in terms of our mental health areas, and then in terms of suicide ideation. So next slide, please. This is becoming one of my favorite diagrams here. And don't show that one yet, Scott. Okay. When you look at this, every section has its own team that's building this, content developers. Again, this is powered by MD Logix. We went with the platform because this platform is multi-purpose, and we're also talking about connecting data hubs. So again, it's a very extensive opportunity for us to connect all the dots, like that's our theme. But when you look at the youth side, that particularly focuses on information for youth, not an overloaded site. It's going to have a mini screener, and then it's going to direct youth to help and then provide background information for themselves or their peers. Families, that section, again, is specifically designed for families, in terms of where to go for help, current information. Again, we're loading the best of the best. All of these groups are doing the vetting. They're content vetters. And again, everything on here will be validated programs and products. The educators, that site also will provide information to educators in terms of supporting their efforts for families and youth. And the other part of that that's critical is that that's a self-help mechanism. As a school psychologist, I show up on a daily basis, and one of my concerns is losing a staff member. And if anybody's familiar with what's going on in the medical community, realize that we turned our school personnel into first responders. So again, that's critical to be aware of. 24/7 critical helpline there. That's more than an 800 number. There's actually a team behind that we're developing. And that's the go-to team for a school superintendent or somebody in the community. Yes, they have the resources and usually teams, but this is a side-by-side buddy for the first 48 hours of a crisis. And so again, we're looking at that. When you go to the right side of the diagram, that's where we start getting into the professional pages, that are structured there for the particular professional. Imagine going to a BHLC community use in your state and having everything loaded on here that people are doing, county by county, people who are involved in projects, people are looking for partners, what grants people are going after. So again, it becomes a world of collaboration here. The Research Data Hub is critical because again, one of the benefits we have is real-time data. And again, a lot of the data that we worked in the past on is 2-3 years old. So again, a lot of states pretty much are in the same boat there. So that's a critical piece right there. And again, this draws research directly to the field, and there are universities that are interested in this area. The trainings are critical right there because again, 24-hour, 7 days a week access to trainings, their modules. And again, if we're going to mandate trainings in the state of Michigan for all personnel, it's critical for us to be able to support it and have access. One of the things that we're staying out of is that small square, that small space where everybody competes with districts trying to get training in there. We're going after that 24/7 access, and then cross training between agencies is critical there. So a lot of potential offerings and things that can happen in that space that we're excited about. bhworks ecosystem are the actual users of bhworks. So as you can see, we're building a very comprehensive approach, a comprehensive, sustainable approach in terms of supporting all of our mental health providers. But at the same time, imagine training, and I think we came up with, and I might be wrong, 250 to 300,000 employees within the world of schools in Michigan. And if every one of them was trained with like a QPR training, they'd have the skill sets to identify there might be something wrong with that child, like a bus driver sees that child the first part of the day and the last part, and then be in the position to ask the question and support the referral in that. But just imagine that bus driver taking it home to support his efforts as a parent as a good neighbor, as a good community member, we're going to be attacking the stigma big time from that perspective. I'm going to kick this over to Scott and Kevin and for the slide.
Kevin, you want to start or you want me to? You got to be off mute if you want to start, though.
I'll let you take this one.
Okay, sounds good. So, how do we bring all of this together? It's obviously, you've heard we've got some very big ideas here in Michigan, and we want to be very intentional about, as Nick said, saving lives, really making sure that we're creating a system that has the capacity to get students the support that they need. As I mentioned before, the last thing we want to do is get our students that are vulnerable and transparent about their feelings and then turn around and not be able to provide them with the help that they need. So we have two guests with us that are here as well. Kimberly Batchelder from the Michigan Health Information Network and Alan Tien, who's the president and CEO of MD Logics. Two content experts that are here to help answer any questions that you have about either this particular slide, which I'm going to cover here, or about the bhworks platform that I mentioned before. But this slide kind of brings all of it together and is also the next part of our, it's been called the Michigan Miracle, affectionately by, I think it was Nick Ialongo, who's a professor at, is it Drexel University, Nick, where he's at, or Johns Hopkins?
Is that Johns Hopkins, sir? Johns
Hopkins, thank you. Yep. So, you know, when I first heard that, I thought, oh, that's an exaggeration, like, but you know what? It really is a Michigan miracle that we're trying to pull off here. And Nick talked about that amazing relationship that we have at the Department of Education with the Department of Health and Human Services. It's not about, you know, taking credit, or it's not about a territorial thing, as Kevin used the word silos. The priorities for us have been from the beginning, let's not just break down silos. Let's tear them completely down and get rid of them altogether. Like, you know, you hear the expression, oh, we're going to break down silos, but we want to destroy those and really concentrate on what's most important, which is the students in Michigan, so that they can, you know, prosper and grow to be responsible adults that can take care of their own children. And so this slide here is the culmination of all of the things that we've been working towards. And it's really a way to get the school-based providers connected to the rest of the team members for that child. You know, Kevin talked about before about the one of the Medicare requirements is that integration, the coordination of services. And so how do we efficiently and effectively coordinate services with a child's primary care physician, with a child's psychiatrist if they're seeing them? And we came across the Michigan Health Information Network. And as you can see from this extremely busy visual, it brings a lot of separate networks together when it comes to, again, the care for that whole child. So we've got everything on here from, you know, private insurance and Medicaid, the Michigan Department of Education, the Michigan Department of Health and Human Services, which obviously is very big and encompasses a lot of separate departments. We have 43 provider organizations, pharmacies, CVS, Walgreens, Costco, Meijer, hospital systems, you know, Henry Ford Health System, Beaumont Health, University of Michigan Health System, and more. Consumer-facing organizations, federal organizations. We are looking at a way to connect all of these in a HIPAA, FERPA compliant manner that's confidential, that's trusted, that's effective, that can share information. We don't know if this is something that's going to be 3 years from now, 5 years from now. maybe under a year. We don't know. But it's something that we are very excited about, the potential to, again, be able to connect an entire child's team so that they can share resources and make sure that they're providing the most excellent care possible. Obviously, another huge component of this is the parents and the caregivers, right? How do we connect with them and make sure they're involved with the child's care? So again, we have Kimberly Batchelder on the call Kim, do you want to go ahead and maybe explain just a little bit further about what that integration might look like with the Michigan Health Information Network?
Sure. Can you hear me, Scott? Okay.
Yep. Sounds great. Thanks, Kim.
Awesome. Okay. Well, thank you all for inviting me to attend, and really excited that Scott and team contacted us here at the Michigan Health Information Network. Just a little background: the Michigan Health Information Network Shared Services is is Michigan's state designated entity for health information sharing. We were created about 10 years ago in a partnership between the CMS and our state government partners here. We're a nonprofit organization that's really focused on continuously improvement of healthcare quality, efficiency, and patient safety by promoting secure electronic exchange of health information. And so we basically represent, as Scott's showing right here, a growing network of public and private organizations working to overcome data sharing barriers in order to reduce costs and ultimately advance, the health of Michigan's population. So we actually are an existing network, really focused for the past 10 years on the health side, really working with our provider organizations, our hospitals, our major payers in coordinating care by electronic data exchange, and focus really on making sure that the right data is at for the right person is at the right point of care. So this is an existing infrastructure, and really excited to begin the discussions with Scott and team and bhworks on trying to integrate this platform into this existing network, where we can assist with these and leverage these existing connections to our providers, our hospitals, our payers, and being able to increase that care coordination of the student population. And so again, this is all existing. We do have data flowing to all these organizations for different care coordination purposes. But really excited to add the student population into this. And as Scott said, this is, again, we're just in the beginning stages of this, understanding we have to understand the differences between, the HIPAA and FERPA, being able to share, being able to protect the privacy and security of that information related to that student. And of course, that's kind of our first goal, is to make sure that we can utilize this infrastructure, and leverage it the same way we're doing from a patient perspective for our student population. And so happy to answer any questions, but we're hoping to, again, integrate bhworks into this existing system, or in this existing network, in order to help share that information to the students' providers that are outside the school system, and then bi-directionally share information to help integrate that school-based provider into more a holistic picture of care for that student. Hopefully that helps, Scott.
Yeah, that was great. Thank you, Kim. I appreciate it.
The thing that I'm going to say is when we first came up with the idea to expand into free care, I really did not envision the program that we are leading to now. It's like a lot of people had ideas where they would take the free care idea and go, what if we did this? And it has just snowballed to the point where it's really growing to an amazing platform and amazing opportunities for our kids in the schools. So, and that was just, it's a collaborative effort between a lot of people in the state, and there's really too many to even name at this point. But I was quite amazed with all the collaboration and the way the program has grown.
Well said, Kevin. So with the remaining 10 minutes, we do want to give you an opportunity to ask us questions that you have. We obviously have more things that we're happy to talk about and share, but we'd really love to hear from you if there are questions that either have not been put in the chat box yet or that you've been thinking about. So we'd love to hear from each of you in this last 10 minutes if you have questions.
While we wait for those questions, somebody commented earlier that many places seem to be willing to go back to where we were before COVID. And one thing that Nick and Scott and I have said all along is that, you know, with the tragedy of COVID, the real tragedy is if we don't emerge on the other side of it better than we were before we went in. You know, we got to take those lessons learned and apply them.
We have a question. They're asking, can you provide Kimberly's contact information?
Absolutely. I will go ahead and go to the next slide where that is located.
Perfect. We also have, thank you for excellent presentation and ideas, fascinating program. Thank you for sharing. A lot of thanks out there for a great presentation, guys.
Appreciate that. Kevin, do you want to, since we don't have any questions coming through, it doesn't look like, actually, we just got one. Will this data capture eventually be expanded for all student health needs? Nick, do you know what that question? I'm not 100% sure if I know how to answer that, or should we ask for more clarification?
A little bit more clarification would be great.
Linda, can you come off mute and give us a little bit more background on that, please?
Well, being more familiar with the outside of the mental health aspect, I think the question is actually, you know, we have other students with concerns, whether it's the PTOT, speech, things outside of the mental health area. Are those going to be captured? They wouldn't be captured exactly. Thank you, Linda. They wouldn't be captured through the bhworks, but they would be captured as, I believe they'd be captured as they went through the Michigan Health Information Network and things like that. So there is a different level of coordination there, if you will, but I believe that eventually that too would be captured.
Thanks, Kevin.
There's from Charles, nice works. Suggested ways of overcoming data sharing barriers, not just HIPAA and FERPA, but CFR too. Not sure what that is.
Kimberly, is that something you're familiar with?
Do you want me to take that? So I think you're referring to CFR. Is it the 42 CFR Part 2, which is the restriction of sharing information related to substance abuse and opioid? Okay, I get a yes. So we actually definitely have that challenge within the Health Information Network, just on the health side. We actually are creating a statewide electronic consent management system that's able to collect consents from the patients in order to share information that's particularly related to SUD, OUD information. And so we're in the process of piloting that right now with our community mental health in Michigan right now with 3 of them. We're lucky here in the state because our legislature did pass a law for the Department of Health and Human Services to create a standardized behavioral health information sharing consent form. According to the law, the consent form it must be accepted, but the facility doesn't necessarily have to use that or change the consent process that they have. But if presented with it, they do have to use that. So we're basing our electronic consent system off of that standard form. And hopefully through our pilot that we're currently conducting right now, we're able to be able to connect more of our behavioral health facilities. We actually have a project to connect all of our psychiatric hospitals that are state funded to our network to start beginning that information sharing too. Again, we take that very seriously, making sure that we have all of our messages tagged appropriately if they are coming from a behavioral health facility, and they, only being able directly to share that information if there's a consent on file. And so that's kind of the direction that we're heading related to being able to share, that specially protected information that's governed by that 42 CFR Part 2. As it relates to some of the other health information sharing, we're typically in the past, we're really governed by HIPAA for that payment treatment operations purposes. But obviously with this, the students coming into the system, that's, we're really gonna, one of our first tasks, I believe, Scott, please correct me if I'm wrong, is to form a privacy and security work group so we can make sure that we're abiding by all the laws that govern that information sharing related to a student, and making sure that we're protecting that privacy and security.
Yep, that's exactly right.
Your question.
Thank you. There's another question from Lynette. I'm hearing a lot about dangers of Facebook, Snapchat, Instagram for mental health of children. Are any school systems addressing these with parents?
I can't speak for school. Well, it looks like Nick, you had a response.
Sure. I actually want to go back to OK to Say. They have an active program with schools that talk and address those issues in regards to safety for parents working with their children on social media areas. So again, they're one of our partners in that, and they're based out of the Michigan State Police. And we do have a lot of schools that are very aware of that and are trying to build that into some of their crisis response teams, and then also anybody that's worked with on the horrible side of suicide, where it's into the intervention and postvention. Social media plays a major role that we have to address. So that's a great question. But again, we're more aware of that. And in Michigan, one of the leaders in terms of training is the OK to Say team.
Thank you. Another question, any insight on how to handle the barrier when the need is there for a specific student and the student has spoken up, but the parent will not give consent for services because the parent does not buy into mental health and believes depression and anxiety are not an accurate diagnosis?
So I'll tag team this with Nick. He's a school psychologist. But to start off, the first thing that came to mind when I saw that question is it's all about education. I mean, you have to take the time to help the parent understand the importance of so that they get past that stigma of, well, again, as they said, it's not an accurate diagnosis, or my kid's fine, they're tough. You really have to invest time with that parent to help them understand the impact that, and you may not want to use the words like depression, anxiety. If those are trigger words for them that cause them to be frustrated and tune out, you may need to describe it a different way. Like, well, we have an idea where we can improve your child's grades, or we can improve their attendance, depending on, what the issues are, the outlying behaviors that you're seeing. Working with that family to create a plan collectively and together is going to be critical, because obviously there's a barrier up right now when they see or hear about mental health. So you need to educate them and help them understand the impact that a behavioral health provider could have for them. Nick, what would you add to that?
Scott, you're so spot on, everybody. It's so critical, that education, that's supporting the parents, getting the information out, working together as a community. And that's the reason why that spot is on the BHLC for parents. That gives us a working mechanism to get that information out. Kevin, the person that put that in the chat about the COVID-19, and Kevin talked a little bit about that. COVID-19 has opened up a lot of areas. and some positive, in terms of getting us all together, and some of the meetings wouldn't happen if we had to travel, so that's a positive thing. But on the other side, COVID-19 has been a humbling experience to schools. Is we thought we had better connections with parents, and we thought we had better connections with their kids. But if you look at some of the kids who went AWOL, period, and didn't return to schools, and there was no contact. So we need to be aware of that. And so part of what we're saying today is that this is a real call to action, is that, and help me out here, Kevin and Scott. Dr. Rice really frames it very nicely. Our state superintendent is that, we're looking at 3 years here of potentially good funding to get it right. And so that's been our mantra also, is, let's get this in place for kids and all of us working together. And again, we as states share the same issues across the board. But Scott, that's a great question. It is spot on. We got to do this together, and we got to meet parents where they're at. And the things that we're doing, Sunday we can see getting into the home and working with parents virtually, instead of bringing them into schools, in the middle of the day during work time. So again, the potential of recreating what we do in mental health and the potential of changing the ecosystem is really what we're after. Thank you.
Liza, we'll turn things over to you to conclude for us.
Okay, thank you everybody for joining us for this session. Gentlemen, that was amazing. A lot of information very quickly, but boy, you guys explained it. Some of those slides there, Nick, I was all busy on those slides, but that's okay. Just to everybody know that the slides are at the bottom of the session page, and the recordings will be available tomorrow for you to rewatch for a week, and then we will be putting them on the NAME website members only section. This concludes today's presentation of the NAME 19th annual virtual conference, and I hope everybody has a great afternoon. Thank you guys so much.